I think I've started screen sharing. Can someone write on the chat?
We can see.
Oh, thank you. Okay. So I can start. Okay, so we can start. Okay, basically, Mbogi Genje production. So Mbogi Genje was a discussion group, was actually my discussion group. We were 9. We had this discussion group back when we were reading for India. And so I'm using that study material to lead the session today. Okay, so so we start. So this slide, as you can see, so basically I've written the topic, and then there's an image attached, and then there's questions below it. Okay, that's how it's going to be. So from this slide, so these are Plasmodium trophozoite. You can see these headphone-shaped things inside the RBCs. I hope you can see them here. So if you asked what is the abnormality, you say presence of Plasmodium trophozoites. Here they are, if you can see them here. Can you see my cursor? Don't know. Yeah. So if you ask the abnormality, presence of Plasmodium trophozoites, then they'll ask 3 hematological consequences that present in this patient. So in order to understand, I divided them into 2. So we have blood and liver. So for blood, this is a patient who has malaria. So we expect anemia. And with anemia, we expect thrombocytopenia. Then eosinophilia. So because it's a parasite, and we know for parasites, there's raised levels of eosinophils. Hemolysis, which is the destruction of the red blood cells. Yes, so you can imagine there are trophozoites inside the RBCs. They get congested and then they burst. Now that's the hemolysis. Then eventually it can lead to bone marrow failure. And for the liver, we have splenomegaly. Then for jaundice, so jaundice is an increase in bilirubin levels. And then so hepatomegaly, basically hepatomegaly, which will cause jaundice. I hope that's clear. And then for supravital staining, as you can see here, you can see these cells, kind of bluish in color, purplish. I'm not so sure. Yeah, so bluish. Then you can see some things inside these cells, darker in color compared to the cells. So from this, you'll be asked, name the preparation. So for the preparation, do not write supravital staining. That's not the preparation. The preparation is reticulocyte count. We are counting the reticulocyte here, okay? That's a very common mistake here. When you ask the preparation, make sure you don't write supravital staining, okay? Now, the procedure, what we are doing is this supravital staining. These are the stains we use doing this procedure, okay? The preparation of reticulocyte count. 2 dyes that we use, new methylene blue and brilliant cressyl blue, okay? Yes, I think that's clear. Then the reference intervals of the results, preparation. So you'll be asked in adults and in infants. In adults, we expect them to be less than 2%. So basically 1 to 2%, that's okay. But in infants, 2 to 6%, it is slightly more in infants. Then for here, identify causes of increased synthesis and decreased synthesis of the above cells. So we know they are reticulocytes. So reticulocytosis. Number 1, hemolysis. When you have destruction of red blood cells, you'd expect the bone marrow to produce more retics, isn't it? So that's why in hemolysis and blood loss, so acute hemorrhage or chronic hemorrhage, you'll expect the reticulocyte count to spike up. Okay, not so much for acute hemorrhage, but for chronic hemorrhage, you'll expect the number of reticulocytes to be way, way higher. Then hypoxia. What is hypoxia? So hypoxia is low oxygen in the tissues. So if there's low oxygen in the tissues, This means that possibly there's low RBCs transporting oxygen. So what will happen? Your body will produce reticulocytes to produce more RBCs, isn't it? Yeah. Then some drugs, for example, recombinant human erythropoietin. So the question here is human erythropoietin. So erythropoietin, we know, is produced in the kidney. And what's its function? It stimulates erythropoiesis, okay? So, for example, mostly it's used in chemotherapy. You know, like, for example, chemotherapy drug reticulocyte count. Yes. So we use the recombinant human erythropoietin, and it's usually abused by these runners, the athletes, in order to increase their red cells. Yeah. So, for example, if you're an athlete and you run, so if you have more red cells, you'll have more oxygen delivery to the tissues, so to the muscles you're using to run, for example, the quadriceps. So they usually abuse it. So it's actually banned in sports. Then decreased reticulocyte count, chronic kidney failure. The relation is kidney produces erythropoietin, and if you have decreased erythropoietin production, you'll have decreased reticulocyte count. Some drugs, for example, chemotherapy drugs, which makes sense because these drugs cause myelosuppression, isn't it? Yes, and if they cause the myelosuppression, the cell line of the RBCs, which are the retics, will decrease. Bone marrow failure, for example, aplastic anemia, Fanconi anemia, myelodysplastic syndrome, they all cause decreased reticulocyte count. Yeah, so be careful in the exam. One thing you have to note is when you write aplastic anemia, you can write aplastic anemia, Fanconi anemia, or myelodysplastic syndrome. But if you write bone marrow failure, do not write aplastic anemia, Fanconi anemia, and myelodysplastic syndrome. That's 1 mark. So be careful. If you want to write bone marrow failure, just write it alone. But if you don't want to write it, just write aplastic anemia, Fanconi anemia, myelodysplastic syndrome. Those can be treated as separate marks, but make sure you don't write bone marrow failure and aplastic anemia at the same time. Yeah. So for the myelodysplastic syndromes, basically the causes, the primary cause is unknown, but for the secondary causes, it's usually secondary to chemotherapy, radiation, for example, benzene exposure. It usually causes myelodysplastic syndrome. Yeah. Then the next question, identify the stages of development stroke erythropoiesis. So from this, so basically what they're asking here is the RBC cell lineage. So it's divided into two. We have in the bone marrow and in the blood. I can use this diagram. So this is a second year work. So you have to remember it has to start from somewhere. So in the bone marrow, we have the hematopoietic stem cell. That's the first one that we have. Then the hematopoietic stem cell will give rise to proerythroblast. When you look at this proerythroblast, you can see it's quite large. Okay, not that large, but it should be quite large, slightly oval. And the cytoplasm, as you can see here, it's blue. And the nucleoli here should be very prominent. Okay, that's how it is. So stem cell, then proerythroblast. Then the next one is erythroblast. For the erythroblast, the nucleus will decrease in size. So we expect a smaller nucleus. And the nucleoli, which is inside, it should be absent. Okay, so here we have the nucleus and the nucleoli. When you go to the erythroblast, it should be absent. And then the next one is the normoblast. For the normoblast, the nucleus becomes compact. Okay. And then the cytoplasm, as you can see, this one was blue. It's becoming slightly reddish, as you can see. Yeah, because at this stage is where hemoglobin synthesis increases. So that's why of that color. And then the reticulocyte, of which we saw above. Can you see these granules inside the reticulocyte? Yeah, these are the organelle remnants. Okay. Yeah, so these are the ones we actually visualize when we do the reticulocyte count. As you can see here, these organelle remnants inside the reticulocyte, the blue ones, they're usually blue in color. And then the erythrocyte, which is just the RBC, it's biconcave and it has no nucleus. Remember, it's not nucleated. Yeah, and then the granules that were in the reticulocyte are absent. Yeah. So I hope that's clear for this. This is all the questions we can ask there. Then for the next one, hemathriosis. So basically, you'll be shown a knee with the accumulation of some fluid. You actually can't know if it's blood or if it's anything, pus. You can't know what it is, but you can imagine, look at the knee. There's an accumulation of some fluid. So it's known as hemathriosis. But you'll be asked, state the abnormality. If you ask state the abnormality, don't say hemathriosis. That's not what you're seeing. You're seeing a swollen knee. Okay? Take note of that. It's a swollen knee. And then if you ask, state the 3 likely congenital hematological causes of this condition. So you've been given congenital hematological causes of this condition. So trauma can't be an answer, though if it were just causes, trauma would have been an answer. Okay, yeah, because you can't know even if it's synovial fluid or anything. But congenital hematological, they're usually 3: hemophilia A, B, C, or severe stroke type 3 von Willebrand disease. These are the ones. Okay, yeah. Desired blood products indicated in this condition. So for here, we are looking at blood products for hemophilia A, B, C, and or severe VWD. Note here, one thing you should remember, you can't start saying, for example, hemophilia A, where it's deficiency in factor 8, you can't just start saying factor 8 because those are not blood products. You have to check the question, okay? So for the desired blood products, FFP, fresh frozen plasma, which has now the specific factors, and then cryoprecipitate, which we know it has VWF, and factor 8 for hemophilia A, okay? Then mention 3 other clinical features of the patient might present with. Epistaxis, which is nosebleeds. So here what they're testing is you're trying to see what conditions may present with someone who has hemophilia. So factor 8 is not present. So think of bleeding conditions. For example, epistaxis, melena. Melena is indicative of upper GI bleeding. Hematemesis, this is vomiting of blood. Hematuria, this is blood in the urine. Excessive bleeding following small procedures, e.g. dental procedures, recurrent bruising, stroke, hematoma formation. Hematoma basically is a collection of blood under the skin. Yeah, I think there's a picture here. We're going to see it. So if you see clinical features, just think of anything related to bleeding. You'll get it correct. Then one thing here I put, because I was seeing very common, is petechiae. So here, petechiae, so you have to ask yourself, what is petechiae? Petechiae forms when there is a trauma to the capillary of the skin. So normally, for example, you hit someone's hand, then you start seeing those they're usually small papules on the skin. You'll see them. So basically the capillaries under the skin, they actually rupture and then they start forming those papules. Those are what is known as petechiae. And petechiae, as I've written here, petechiae is a sign of platelet disorder, not a coagulation disorder in hemophilia. Okay? So basically, if you have thrombocytopenia means low platelet count. That is what will cause petechiae. Because if you have just a mild trauma, normally your platelets, which are circulating in blood, should go form a clot, no damage. But if you have thrombocytopenia, maybe less than, let's say, 50,000 or 150,000 millimeters cubic of platelets, you start forming those petechiae, which are small papules. We're going to see them down there. So this is something to note, that petechiae is a sign of platelet disorder, which is in patients with thrombocythemia, and not a coagulation disorder, e.g. in hemophilia. So note that. Then list 3 laboratory tests useful in the investigation. So PT, prothrombin time, we have APTT, which will be prolonged. So this is in hemophilia. So APTT, there's usually a formula I usually use, trying to remember if it's PT or APTT. I usually say playing table tennis. So you play table tennis inside, so it's usually indicative of the intrinsic pathway. Yes, that's how I remember. And then playing tennis, you play it outside, so it's indicative of the extrinsic pathway. That's how I usually remember that. So for this one, APTT, which is the intrinsic pathway, it should be prolonged because of hemophilia A. So factor 8. Yes, then factor 8 is assay. So to check the level of factor 8, then the bleeding time will be prolonged in VWD. And then ristocetin cofactor assay, that's when you're checking for VWD. So this question is quite general. You can say the lab test used in hemophilia and VWD. Yeah. Then poikilocytosis. So for here, I'd like to engage the chart. I know I've been talking a lot, but I'd like to engage the chart. It can get quite boring. So what kind of cells do you see here? Like, for example, what cell is this? This one here. Can you see my cursor? You can write on the chart. Sickle cell. I can see someone saying sickle cell. Yeah. So you might ask yourself, why is it a sickle cell? Why is it not an elliptocyte? Yeah, that one I'm going to answer. And then what kind of cell is this here? This one here, and also which other one? This. What kind of cell is this? This and this. Anyone, you can try. It's a discussion, so it's not a must if it's correct. This cell and this cell. This one and this one. Anyone who's uh target cell, this one, yes, this looks like a target cell. Small lymphocyte, this one, or this one is the lymphocyte. Yeah. And then so what is this? There's also this one looks abnormal. I'm seeing someone has written to me, nucleated RBC, yes. This one. Yeah. So we can check. So this is poikilocytosis. Poikilocytosis, how I remember, I usually say poikilocytosis shape and then anisocytosis size. So so the P is for the shape, so different shapes, and then anisocytosis is for the size. So so these are the sickle cell. Look, this is the one I was saying. Look at the edges. So for the sickle cell, you check the edges. For an elliptocyte, they usually have blunt edges. So it will look like a sickle cell, but it's usually blunt. Okay. Yeah. Then the next one is the target cell. Yeah, this one, it's not completely a target cell, but a target cell usually looks complete. We're going to see it down there, but yeah, this one it can look like a target cell if it were complete, to look like a target. And then we have hypochromic red cells. So hypochromic basically is so for a normal RBC is this one. Let me see if I can see. Okay, I can't see. This one looks slightly normal, almost normal, but it should be round and it should have a hollow. It should be slightly hollow there. That's a normal one. But now for the hypochromic, it's like, look at this one. You can see it's hypochromic, isn't it? Yeah, it's this one. You can see it's slightly purple. You can see, okay? And then this one is the one I was saying. So this one is now the nucleated RBC, okay? Yeah. So for the lymphocyte, this was the lymphocyte, okay? So the lymphocyte basically is um, used to compare the size of the RBC. If like this one, you can see it's the size of the lymphocyte. So this is it's usually used to compare. So if it's larger, that's a macrovalocyte. If it's smaller, it's a microvalocyte. Yeah, this one. This is the perfect one. Look at this. What cell is this? Anyone in the chat? I'm seeing someone has written hyperchromic. Yeah. Uh, so as you can see, this one, it looks like it's dense. It's dense in color because for a normal one, you expect it to have like slight hollow, like white on the background. So this one is I don't know if, is there a term like hyperchromic red blood cell? Asperocyte. Yes, asperocyte. Yeah. It's hyperchromic. It's dark in color. Okay. Uh, um, here. Oh, so Alex has told us here. You should say, you see sickled cells. Yeah. Okay. Are you seeing? You see sickle cell, you put in sickle cell. Yeah. So sickle cell anemia is the condition, and the type of cells are sickled cells. Yeah. Okay. Then which test is performed to test polychromatic cells? Reticulocyte count. Yes, so three complications that the patient with the abnormality may present. So this patient has sickle cell anemia. So you have to mention any complications of sickle cell. So leg ulcers, avascular osteonecrosis, cardiomyopathy, osteoporosis, end-stage renal failure, functional asplenia, vaso-occlusive strike crisis, aplastic crisis, recurrent infection, renal infarcts, papillary necrosis, autosplenectomy, acute chest syndrome, heart failure, sepsis, stroke, dactylitis in children. So there are quite a lot. So they usually ask for three. Yeah, you can say any of these. Yes. Okay. Identify the screening test of the above. So one thing you have to know is there's screening test and there's definitive test. So screening test would tell you the difference between um, a sickle cell trait and a sickle cell anemia. So we have HB solubility test that we're going to see down there when we're doing a question on sickle cell. Then we have sickling test. So this one is positive in sickle cell trait and anemia. HB solubility test, HB is insoluble. Then for definitive tests, so HB electrophoresis, isoelectric focusing, and HPLC, high performance liquid chromatography. Okay. Okay, I hope that's clear. Then for the anticoagulants, so purple, so obviously they want to bring this picture, but this is the picture I found because it's written here EDTA. But yeah, I usually say purple EDTA to remember. So name the anticoagulant, EDTA. If they ask the function, it chelates calcium ions in blood. Yes, and we know calcium is used in the clotting process. It's cofactor. And then name 2 tests that can be performed from the sample collected. So so for this one, there are quite a lot. So I mentioned a few, ESR, PBF, HbA1c for diabetes, bone marrow aspirate, total blood count or complete blood count, reticulocyte count. There are quite a lot. So routine hematological tests. And then there's this one, the blue. So if you see a blue cup, they'll ask, what is the anticoagulant, sodium citrate, the function? It removes calcium from blood. Then if they ask, tests that can be performed, coagulation tests, so prothrombin time, APTT, partial thromboplastin time, thrombin time, blood transfusion. Then I put here a note, do not mention bleeding time. Okay, you might be confused when they say coagulation studies, you mention everything. Bleeding time actually is not done like this. As we'll see, there's Ivy's and Duke's methods. They're not done here. Okay, so don't be confused. So if you just ask 2 tests, I think the best thing to say is maybe PT and blood transfusion, just like that. Then for the green one, though this is not really routine hematology, this is kind of clinical chemistry, but I just put it here. So the green one, anticoagulant, is heparin. 2 tests that can be performed. So we have HLA typing, chromosome testing, ammonia, lactate, osmotic fragility, tests for BGAs, for blood gas analysis. Yes, they use the heparin one. Yes. And then now for the normal red cell values and indices. So I have the table, which is the normal one, then before we go to our question. So first of all, you have to understand this before you interpret anything. So HB, I'm sure this one most of you know. So HB in males 13 to 17 can go to 18, 12 to 16 in female. Then red cell count. So what I usually remember is HB is usually 3 times the red cell count. Okay, so 4.5 to 6.5. So if you don't remember, you can just do these ones divided by 3, these ones divided by 3 to get the range. And then packed cell volume, stroke hematocrit. So you have to ask yourself, what is hematocrit? So hematocrit, remember, it's a percentage. So it's basically the percentage of RBCs in the total volume of blood. So if you have a total volume of blood, what is the percentage of red blood cells in that concentration of blood? Okay, now that is what is a hematocrit. Normally 40 to 54 in males, 37 to 47 in females. Okay, that's the hematocrit. Yeah. MCV, look at the unit, femtoliters. MCV, what is MCV? MCV basically shows you the sizes. So sizes, so the normal is 76 to 96 or 80 to 100. So if it's less than this, meaning that the size of the cells are smaller, if they're smaller, we call it microcytic, okay? If it's greater than 96 or greater than 100, they are larger, so they will be macrocytic. So those are macrocytic cells. So micro is less, macro is larger. MCH, I can ask yourself what is MCH and look at the units, picograms. MCH basically is mean cell hemoglobin, okay? So what is mean cell hemoglobin? It's basically the quantity of hemoglobin in a single RBC. So this is an RBC. What is the quantity of hemoglobin in it? That is the mean cell hemoglobin. Okay. So, so if you reason out, when you have a decreased MCH, if the quantity of hemoglobin is low, what do you expect? So most likely that is a iron deficiency anemia, isn't it? Okay. But if you have increased MCH, you have something like macrocytic anemia. So like if you have macrocytic anemia, meaning the cell is big, so there's so much hemoglobin inside the cell. So that's for MCH. Then MCHC, mean cell or mean corpuscular hemoglobin concentration. Now that's the difference. Note the difference. This is a concentration. This doesn't have concentration, and it's in grams per deciliter. So what's the difference? For MCHC, it is the measure of the average concentration of hemoglobin in a given volume of packed RBCs. Okay, so concentration of hemoglobin in a given volume of RBCs. So if there's this volume of RBCs you have, what's the concentration of hemoglobin in that specific concentration? That is the MCHC. Okay. Then reticulocyte count, as you had seen earlier, these are the immature RBCs, and 0.2 to 2, yeah, male, and this is, yeah, so they put 0.2 to 2, can go to around 6 in children. Then the RDW, so the distributional width, red cell distributional width. So basically this is just how the cells vary in size. So they should vary between 12 to 15%. Okay, how the RBCs vary in size. Okay, now, okay, I've written the topic here, but at least we can try and interpret this. So HB, this is low, isn't it? So if the HB is low, we know this is an anemia. MCV is 108. This is quite high. So this is a macrocytic, because we said MCV is for size. So this is a macrocytic anemia. Then MCH is 32, as we saw here. 32 is within range, but normally, so this is not that severe, but normally for macrocytic anemia, we expect the MCH to be slightly higher than 33. But for this one, it's not that higher, but it's okay. This is the most important value. So from the printout, what are the likely causes of anemia? So someone from the chat can just say which causes they know, then we're going to discuss them. Causes of macrocytic anemia. Folate, B12 deficiency, B12 deficiency, folate deficiency, yeah. So, liver disease, alcoholism, hypothyroidism, yeah, those are all the causes. So for macrocytic anemia, you can divide the causes into two. So we have megaloblastic and non-megaloblastic anemia, okay? So of all these causes, I'll give you a way to remember them. So we start with megaloblastic. So what is megaloblastic anemia? So megaloblasts, they are immature RBCs that are large. See, this is microcytic anemia. So we expect them to be large, and they must have DNA. So that's how you remember. Sorry. For megaloblastic anemia, the cause of this the large red blood cells is impaired DNA synthesis, okay? That's the cause of this megaloblast compared to the non-megaloblastic causes. So vitamin B12 deficiency. So if you write vitamin B12 deficiency, I think the best thing you're supposed to do is you give an example. Like I tried to categorize them into decreased intake. So for decreased intake, complete vegetarians. So this one is quite rare because For B12, in complete vegetarians. So first of all, what you have to know is B12 is only found in meat. Okay. So dairy products. So dairy products like milk and meat. So that's why I wrote complete vegetarians. Those are the people who don't take either dairy products or like meat and milk. But why I'm saying this is rare is because um, the liver stores vitamin B12 for around 3 to 6 years. So you can imagine if you stop taking meat or milk from today, you'll exhaust your B12 stores in 6 years. Compared to folate, as we're going to see, the folate ones, it stores 3 to 6 months. So getting a folate deficiency is easier than the B12 deficiency. Yeah, so I hope that one you've understood. Then impaired absorption, I divided them. So we have pernicious anemia. So pernicious anemia is a very high yield. I can take some time to explain. Pernicious anemia, what is pernicious anemia? So first of all, you have to know this is the most common cause of vitamin B12 deficiency. Okay. The cause, autoimmune. This pernicious anemia is an autoimmune disease. So there's autoimmune destruction of intrinsic factor or the parietal cells in the stomach that produce intrinsic factor. Okay, those are the two ones. This is also high yield, also, especially even in MCQs and the essays, they can ask. So pernicious anemia is an autoimmune condition where you have autoantibodies that destroy intrinsic factor or parietal cells that produce intrinsic factor. Okay, so how is it related to vitamin B12? Intrinsic factor binds vitamin B12. Okay, so you can imagine you have food that has B12. Let's say it has been broken down by the enzymes and then B12 is released. When B12 is released, it will bind to intrinsic factor. They'll form a complex, and then this intrinsic factor is the one that is absorbed by the enterocytes in the ileum. Okay, vitamin B12 is absorbed in the terminal ileum. Okay, so that is how pernicious anemia causes with vitamin B12 deficiency. Hope that's clear. Then we have gastrectomy. So gastrectomy is when you remove, so it depends, it can be all or some part of the stomach. So how will removal of the stomach cause vitamin B12 deficiency? Two ways again. Number one, decreased intrinsic factor production, because imagine if you remove part of the stomach, you're removing the parietal cells that produce intrinsic factors. And then number two, you're also decreasing HCl production. So what's the relationship? So for HCl production, you take meat. Let's say you take meat. So this meat will be broken down by HCl. So the HCl is an enzyme activator. It will activate pepsinogen to pepsin. Then this pepsin is the one that will digest the meat, which is protein, into peptides. And then when it's digested, it will release the B12 from the pepsin, okay? So you can imagine if you have decreased HCl production, what will happen? You won't activate pepsinogen to pepsin, which will break down the meat to release B12. So gastrectomy goes together with certain drugs. So same with PPIs like omeprazole, which is a proton pump inhibitor, inhibits HCl secretion, will also lead to vitamin B12 deficiency. Same to gastric bypass. Gastric bypass is basically you're bypassing the stomach. Usually, if you read more about that procedure, it usually bypasses the stomach and the duodenum. So food comes directly from the esophagus, goes through, then it bypasses that, it goes to the jejunum, then the ileum. So basically here, food passes so quickly such that it's not, B12 is not released from the food. So you'll have you won't absorb the vitamin B12. Terminal ileal disease, so for example, Crohn's. Sorry to drive into an patho, but if you remember Crohn's, we had something known as transmural inflammation, which basically means inflammation of all the stomach layers. If you remember some physiology, the stomach layers, we have the mucosa, the submucosa, muscularis propria, and the serosa. So it's all those layers of the stomach are damaged. And when you damage these, you're damaging the enterocytes. So you won't have absorption of the vitamin B12. Okay, that's how Crohn's affects vitamin B12. And also we have, remember in Crohn's, we have something known as the strictures. If you see there's something, we call it the string sign. If I can remember, the string sign, when you see in imaging, you'll see the formation of those strictures. A stricture is a narrowing. So like if you're seeing on the wall of the intestine, there's a narrowing, then it continues, it narrows, it continues, it narrows. So when you can imagine, if your intestine is full with narrowings, narrowings, and narrowings, you'll have some impaired absorption. Okay. Yeah, so for D latem, this one we did it in microbiology. So D latem basically will just attach itself to the wall of the intestine, and that B12 that it's supposed to absorb, it will the D latem itself is the one that's going to be absorbing the B12. Then certain drugs, this one I've explained. Okay, so for B12, as much as you've mentioned B12, you can mention any of these. Or for example, I've seen in an essay question where they bring such a question like this, and then they'd ask, I think we actually did that question, causes of this anemia, and then you'd see the marks is like 12 marks. So you just can't mention vitamin B12 deficiency and you don't give these examples. So you have to give all these examples. But I've tried to explain it, so you don't really need to cram. Yeah, if you just understand it. Then for B9 deficiency, decreased intake, which is alcoholism. This is actually the main cause, alcoholism. So for alcoholism, notice I've written alcoholism. So this is a chronic alcoholic who takes alcohol. So this is taking alcohol on a day-to-day basis. So one, how I'd explain it is, the alcoholics, you can imagine, first of all, I have to mention B9 is found in certain foods. So B9 is found in vegetables, in meat. So getting this deficiency is quite rare. It's you won't get it. You won't get it like if you say you decrease intake. It's not that common. But for alcoholics, these people, you can imagine if you continuously drink alcohol all the time, all the time, all the time, taking of food is quite, I don't think they'll eat B9 rich foods, yeah, like the greens that I've mentioned. Yeah, so I'd say that one. And also absorption. You can imagine taking alcohol, it damages the cells of the intestines because it's chronic taking of alcohol. So absorption of B9 will be impossible. Okay. And then intestinal resection. So for B9, remember it's absorbed in the jejunum. So if you resect this part, B9 won't be absorbed. Then increased demands, for example, pregnancy. So pregnancy and hemolytic anemia. So for hemolytic anemia, you have destruction of red blood cells all the time, destruction of red blood cells. So you'll increase the demand of, because this folate, remember folate is used in production of DNA. So more and more and more and more, more and more, more and more cells will be made. So that's consuming a lot of B9. Then some drugs, e.g. phenytoin and trimethoprim. So for phenytoin, how phenytoin causes B9 deficiency? So for B9, its natural form that's not absorbable is known as polyglutamate. And so polyglutamate has to be converted to monoglutamate that is absorbed. So phenytoin usually inhibits that process. Okay. Yeah. And then for trimethoprim, similar to that one of microbiology, it inhibits dihydrofolate reductase. Yeah. Yes, I think, yeah, that one's okay. Then for the non-megaloblastic causes, we have alcohol, hypothyroidism, liver disease, and some drugs. Okay. So I think that's okay. Then um, I'm seeing Alex has something to mention. He's saying, guys, just a quick point, especially for essay, when given such a picture and told what's the differential diagnosis, give the actual diagnosis. Basically, don't say macrocytic anemia. It's not a diagnostic. So just list the causes you people said earlier, okay? So for example, if this comes in an essay, this value is like this, and they ask what is the diagnosis. So this is what we have to say, okay? We know it's a macrocytic anemia due to the interpretation of the data, but you have to say the causes. So you'll have to say these ones, all these that we have mentioned. Those are the differential. That's why you see differential diagnosis is like 12 marks. You wonder why is it 12 marks? So you have to say all this. Okay. Yes. And then list three tests that be used for confirmation of the diagnosis and expected findings. So always start with CBC. CBC, MCV greater than 100 femtoliters, decreased RBCs, increased MCH, possibly thrombocytopenia and leukopenia. That's when you do a complete blood count. Serum folate levels will be low if it's due to B9, then B12. If it's due to B12, serum folate, serum B12 levels will be low. Then a PBF. A PBF, you'll see macrovalocytes. I'm going to show you all these cells. And mesocytosis, which I said is size. Poikilocytosis is shape. And then basophilic stippling, Howell Jolly bodies, carbotring, nucleic RBCs, segmented neutrophils. I'll show you all these cells down there below. Then when you do a bone marrow aspirate, presence of megaloblasts. Then methylmalonic acid levels, elevated in B12 and normal in B9. So to explain this, methylmalonic acid levels, they'll be elevated in B9. So conversion of methylmalonic acid to succinylcholine, you require B12, not B9. So that's why in B12, you'll have the neurological symptoms, okay? So if, yeah, B9 doesn't present neurological symptoms. Homocysteine levels, they'll be elevated in both B12 and B9. Then test for autoantibodies, anti-intrinsic factor antibodies or antiparietal cell antibodies. Notice the order I've said. So this, when also in writing exam, if you say 3, just mention these first 3. CBC, PBF, a must, then BMA, then you can say folate and cobalamin levels. Then these are the rest. If it's an essay and this is like 10 marks, so you have to mention all these. Then clinical findings. So symptoms of anemia: pallor, fatigue, dyspnea, easy fatigability. There are quite a lot. You can mention those. Then neurological disturbances. As I said, this is due to the accumulation of methylmalonic acid levels. So you have paresthesia, decreased deep tendon reflexes, dementia, and you have to remember this dementia is reversible. So it's not irreversible dementia like the old one, like for old people. No, when you start giving B12, the dementia is reversible. And then for confusion, and then we also have confusion. So ataxia, so this one, ataxia, you can remember, this is when it affects the cerebellum. Then we have dementia and confusion. This is when it affects the cerebrum. Then glossitis, beefy tongue. I'll show you how it looks. And then a sore tongue. And then others, we have splenomegaly, fever, hyperpigmentation. Yeah. So these are macrovalocytes, as you can see. Usually you have a lymphocyte to compare with. And you'd see this one is actually bigger. Look at the size. Yeah. And then this, what is this? Anyone on the chat who can write, what is this? This, what is this? Carbot ring, yeah, this is a car. Carbot ring, this is a carbot ring, good. And then this, what are these? Cobalt ring. Yeah, these are neutrophils, but look at the neutrophils. Look at the segments of the neutrophils. How many are they? 1, 2, 3, 4. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Look at the lobes of the neutrophils. They look quite many. So these ones, we call them hypersegmented neutrophils. Okay. Yeah. Then this, what is this? If you showed this, what is this? Anyone on the chat? I'm seeing someone saying Heinz body. So, um, does a Heinz body look like this? No, but so for Heinz body, don't know that I can show you a picture. I don't know that I have a picture. Let me search here and show you. Can you? Yeah. Can you still see my screen?
Yes.
Okay. Now I want you to see the difference between a Heinz body and what I had shown you. So you have to ask yourself, what is a Heinz body? So, yeah, oh, it's not clear. You know that I can zoom. Wow, we even have a good differentiation. Okay, so a Heinz body, sorry, it's not, it looks so small. I think here it's better to see. So a Heinz body, basically, these are their cells that have denatured hemoglobin. Here, if you see, there's slightly blue on the cell surface. Okay. So when these cells, when they present themselves to the spleen, they'll go to the spleen, and then they'll be phagocytosed by the macrophages. And what will happen? They'll lead to formation of these ones. They're known as bite cells. Like it cuts off this Heinz body part. You remain with the bite cells. Okay. So if you see here, this blue part, basically it's the call it the oxidized hemoglobin within the RBCs, this blue part. Okay. Yeah. So these are very good comparison. Inclusions within the RBC composed of denatured hemoglobin, so it's the hemoglobin that has been oxidized. They are formed as a result of oxidative damage or mutation, e.g. G6PD deficiency. Macrophages in the spleen remove the denatured hemoglobin, giving rise to the classic bite cells. Okay, so the splenic macrophages will come, remove that part, then you'll have the bite cells. So if you asked Heinz bodies, G6PD cells, okay? If you asked bite cells, where will you see them? G6PD. Now what I showed you is the Howell-Jolly here. Nuclear basophilic inclusion within the RBCs. So normally during maturation after leaving the bone marrow, erythroblast nuclei are expelled within the spleen. However, in patients without a spleen, okay, you have to note that a patient without a spleen, so basically a splenia, secondary to surgery or sickle cell disease, will have these things. So normally these cells, if we go back to our slide, normally these cells, they usually go to the spleen and they are sequestrated and they die. But in a patient who has no spleen, they'll remain in the blood. So this is what we call the Howell-Jolly bodies. And what you have to remember is they have DNA within them. Okay? So RBCs with DNA inclusion cause functional hyposplenia in sickle cell and asplenia. Yeah. See, someone got it, Howell-Jolly bodies. Okay. Um, um, Then this, what is this? Who knows this? So I've given you a clue. The RNA residues degenerating mitochondria, these dots. Anyone on the chart? Basophilic stippling, yes. So the clue was in the RNA, and you can see these dots. Okay, so basophilic stippling contains RNA. There are two dots. They are found inside the RBCs, and there are so many, you can see. Okay, they're basically the ribosomal precipitates. Yeah. Okay, so contain RNA, common in lead intoxication, sideroblastic, and thalassemia. This is mostly common in microcytic anemia, is where you'll see it. And then this, who knows this? What is this? This, look at these cells. Anyone on the chart? Anisocytosis, someone was answered. Yeah. Anisocytosis, why? Because you can see the different sizes. You can see this is big, this is small, this is big, small, big, small, big. You can see this one is large. Yeah. What is this? What is this? What cells can you see here? Example, yeah, you see this picture and then they ask, identify 3 cells. You can write any cell you can see. Anyone? Bar cells or echinocytes, yeah. These ones, these, these ones. Which other ones can you see? Mm. So if you asked what is this is poikilocytosis because of the shape. You can see this one. Look, this one looks like a bar cell. So bar cells or the echinocytes. Yeah, so they are to differentiate this from an acanthocyte. Is there an acanthocyte here? Basically, an acanthocyte usually slightly round and then some slight projections. And those projections are usually irregular in shape. But for an echinocyte, the projections are more uniform and they're smaller. You can see like they're smaller. Okay. Yeah. Oh, you have a picture here. So a spherocyte, this one's the one you're saying it's hyperchromatic. Schistocyte, irregular concentrated cell, target cell. As you can see in a target cell, that dot. Then there's a sickle cell, acanthocyte. Yeah, compare an acanthocyte and a bar cell. We said the bar cells are the projection is usually smaller and they are more uniform. These ones are varying in size. You can see this is big. See how they're varying in size, but these ones they're more uniform. And then we have a stomatocyte, ovalocyte. Yeah. Mm, so which cell is this? What cell is this? Mm, mm. What cell is this? The pointed cell, this one. What are these? Mm, anyone? Platelets. Yes, they are platelets. Yeah, these are platelets. Those are platelets. So, um, so when you see platelets, don't rush and just write platelets. Make sure you read the question because these people can be very tricky. Considering this image is there for 1 minute, they'll most likely ask you this. Name the precursor cell for the structure drawn by the arrow, megakaryocytes, because they are platelets, okay? Now, when they ask what cells are shown above, platelets. State three conditions associated with the reduced number of the cells. So they're asking three conditions causing thrombocytopenia. Okay. So thrombocytopenia, to recall, decreased platelet counts, less than 150. So the first one, we have, I tried and divide them. I divided them into three so that it's easier to recall rather than cramming. Decreased production due to splenic sequestration and then increased platelet destruction. Okay. I find this easier to remember. So let's start with the decreased production. So decreased production, e.g. in bone marrow failure, like aplastic anemia. So for this one, how you think about it is when you have bone marrow failure, you'll affect all the cell lines. So from the RBCs to the leukocytes to the thrombocytes, you affect all the cell lines leading to thrombocytopenia. Some drugs, chemotherapy. Chemotherapy, remember we said it causes myelosuppression. And when you cause myelosuppression, you also affect all the cell lines. Leukemia, 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 thrombocytopenia, and anemia are usually secondary to it. And yeah, for leukemia, remember you'll have increased number of blasts, the immature cells of the leukocytes. So that's decreased production. Okay. Then due to splenic sequestration, what is splenic sequestration? Splenic sequestration is destruction. So notice how I've written splenomegaly with active hypersplenism. If you just write splenomegaly, the leg said you won't get a mark. So you have to indicate that as much as there's splenomegaly, the spleen is overworking, okay? And liver cirrhosis. So let me explain this concept. So which one comes first? Liver cirrhosis comes before splenomegaly. So when you have liver cirrhosis, one of the complications is portal hypertension. So what is portal hypertension? Portal hypertension is when blood draws away from the liver, going to the other organs. So like you'll have increased pressure in the spleen. So blood will draw from the liver, away from the liver to the spleen. And what happens when you have blood to back up into the spleen? You'll have something known as congestive splenomegaly. Okay. So when you have congestive splenomegaly, this will make the spleen to hyperfunction. Now that hyperfunction is what we call hypersplenism. Okay. Basically, it's just overworking of the spleen. And you know, the function of the spleen is to destroy these, in quotes and quotes, the weird cells that we have. Okay. But now here, when you have hypersplenism, it will not only destroy the weird cells, but the non-weird cells. Look, so for example, here, when you're talking in regards to platelets, so the normal platelets that are circulating in blood will start being destroyed by the spleen. Okay. So that's one way, splenic sequestration. And then the liver itself, why it can cause thrombocytopenia without involvement of the spleen is because if you recall, what hormone produces platelets? It's known as thrombopoietin. So thrombopoietin is the one like erythropoietin, which EPO, erythropoietin, stimulates erythrocyte production, which is RBCs. And then thrombopoietin, TPO, produced in the liver to stimulate production of platelets. So if you have liver cirrhosis, which is destruction of the liver cells and damage, you won't be able to produce thrombopoietin, and as a result, low platelet count. Okay. Then the next one I did was increased platelet destruction. So this can be divided into two. We have ITP, immune thrombocytopenia, and these ones are the immune-mediated ones. And then the non-immune mediated ones are TTP, thrombotic thrombocytopenia purpura, disseminated intravascular coagulation, DIC, and HUS. So basically here, we have destruction of the platelets in ITP, okay? That's the immune-mediated one. For the non-immune mediated ones, for example, like DIC, we'll have both clotting and bleeding. So it's kind of a paradox because one, you'll bleed. So when you bleed, you'll use so much platelets. And when you use so much platelets, you'll have thrombocytopenia and then you'll continue bleeding. And then because you have little platelets, you'll continue bleeding. Then you'll use up those little platelets to stop the bleeding. Then because you have little platelets, you'll continue bleeding. So like there's an imbalance between bleeding and coagulation. So that's for DIC. And then for HUS, this is now the destruction of the thrombocytes. Same to TTP. You have an abnormal clots forming. And if you form abnormal clots, what will happen? You'll be using up your platelets, leading to thrombocytopenia. Okay, so I hope you've understood that. So it's easier to understand. Then clinical features of decreased number, so thrombocytopenia. So think of anything bleeding. So petechiae, as we mentioned, remember that up there I said petechiae is not a coagulation disorder, but a disorder caused by reduced platelet count. Okay, it's not a coagulation disorder. You have to remember that. So petechiae, bleeding gums, epistaxis, prolonged bleeding after surgery, ecchymosis, purpura. Basically, purpura is just a large petechiae. Bleeding from mucocutaneous surfaces, so maybe gingival, vaginal, GIT. Okay, yeah, so you have to remember that. What is this? So this looks like spooning of the finger. What do we call this? The medical term. Anyone on the chat? Koilonychia, yeah. This koilonychia, common in iron deficiency anemia. So koilonychia. And then what is this? What is this? Look at this tongue. Look at this tongue. It looks, what's the name of this tongue? It looks like a very smooth tongue. There are no grooves. You'd expect the tongue to have grooves. This one is quite smooth. Beefy, who was an alternative answer? Beefy. Anyone in the other answer? Atrophic glossitis, yes. So I'll show you a beefy tongue. So this is atrophic glossitis. Look at this tongue. You can see it doesn't have some grooves. Are you seeing? Yeah, it's soft, the lack of grooves. So this one is atrophic glossitis. Okay. Now look at this tongue. Oh, sorry, I'm sorry. Where is it? Look at this tongue. Compare that tongue and this one. First of all, this looks like a very large tongue, and then look at the grooves. Now this is the beefy tongue, okay? Beefy tongue. So this one, you look at the corner of the mouth, looks swollen. Look, yeah, and here, yeah. This is angular stomatitis. So I hope you've understood the difference between atrophic glossitis and a beefy tongue. So you look at the grooves. You look at the grooves. Okay. Then yeah. So what is this? For example, yeah, I'd ask you, describe this. What is this? Lyric, I think you mean lytic lesions. Multiple punched out lesions. Yes, punched out lesions. So look at this. Oh, sorry. Look at this. Are you seeing this? It's not a normal head X-ray. There's some black substances here. These are the lesions. We call them punched out lesions. Basically, this is what we call the raindrop skull appearance. Yeah, raindrop skull appearance of multiple myeloma. That's the name of the abnormality. So if you're told to describe it, you just say it's a multiple well-defined lytic lesions uh, or punched out lesions of various sizes that are scattered throughout the skull. Yeah, because they said describe. If they were just to state the abnormality, you just say raindrop skull appearance of multiple myeloma. Because you're describing, you have to say there are multiple punched out lesions scattered throughout the skull. Okay. Hematological condition associated, multiple myeloma. 3 tests for diagnosis. These ones, there are a lot of tests. So at least who can mention in the chat, uh, there are very many diagnoses for multiple myeloma. So uh, let's see, we have sorry. SPP. If you write SPP, remember UPP. Yeah. BMA. Those are 3. Another one, Benz-Jones. So Benz-Jones is a finding, but what is the name of the test? Benz-Jones is a finding. So what is the name of the test? So the test has a name. Uh, so one more test, then I can reveal the answers. Any other test you can think about? I'm seeing IFA. What is IFA? I don't know. What is IFA? I can't seem to know what is I. What's the long form of IFA? Immunofluorescence. Oh, okay, yeah, immunofluorescence assay. Okay, yeah. So the first ones I usually remember are UPP and SPP. So urine protein electrophoresis. So that is if you want to write in full. UPP. So if you're told, you can be asked, name 3 tests for diagnosis and expected findings. When you ask that, you'll say, we show presence of paraprotein. So IgG, IgA, light chains, that's what we expect to see in UPP. Same to serum protein electrophoresis, we'll know presence of paraproteins. Okay. And then we have Bradshaw test. So the Benz-Jones answer would be correct, but the test is known as Bradshaw test. Okay. So the Bradshaw test, and then you'll see the presence of Benz-Jones protein. Okay. Then you forgot PBF. When you see a hematological test, don't forget CBC and PBF should be the first things that come to your mind. Okay. CBC, complete blood count, peripheral blood smear. Then now you start going into the clinical chemistry ones. Okay. So in a PBF, what do we expect? Rollo formation. I think there's a question on Rollo we're going to see, but basically the RBCs usually stack up in to form like when you stack up coins. Okay. So that's what we call the Rollo formation. Who can tell me which other condition presents with Rollo formation? Um, any answers in the chat? So, so HIV, yes, HIV, sickle cell, polycythemia, anemia of chronic disease, HIV. So the tests that I'm sure of is so basically so in multiple myeloma, you'll have to remember that sorry, um, a minute, sorry. Okay. Also, I was saying in multiple myeloma, what you have to remember, these are plasma cell disorders, isn't it? So we have multiple myeloma, monoclonal gammopathy of undetermined significance, and Waldenstrom macroglobulinemia. Those are the ones that you think of when you think of Rollo. Then there's also HIV. For polycythemia, I don't know whether that one I'm not sure. Anemia of chronic disease, that one I'm not sure. And sickle cell, yeah, unless you confirm. But what I'm sure of is HIV, and the plasma cell dyscrasias. They present with a Rollo formation. Okay. Maybe someone in the chat can check for us those others. But what I'm sure of, HIV and the plasma cell dyscrasias. ESR, usually high. Okay. CBC, anemia. Then in advanced cases, you'll see neutropenia, thrombocytopenia. Then BMA, abnormal plasma cells, because it's a plasma cell dyscrasia. Then clinical features of the above condition. In the chart, I usually have a mnemonic crab who can check. So clinical features of multiple myeloma. Anyone who can write on the chat, clinical features. If I've already said you have anemia here, so clinical features of anemia, think of that. In advanced cases, you can have neutropenia. So think of neutropenia or think of thrombocytopenia. Okay. Um, so I'm seeing, yeah, lethargy, fatigue, those are clinical features of anemia. So if you have anemia, the first thing you think about is um, you think of symptoms of anemia. So lethargy, fatigue, dyspnea, those are the features of anemia. If you have neutropenia, I was saying, if you have anemia, think of symptoms of anemia. If you have neutropenia, the first thing that comes in mind, recurrent infections. If you have thrombocytopenia, easy bruising, easy bleeding, okay? So think of that. So bone pain, this is usually the first one, especially backache resulting from vertebral collapse and pathological fractures, okay? Features of anemia, as I've said, recurrent infections because you have neutropenia, features of renal failure, so or hypercalcemia. So you'll have anorexia, vomiting, constipation, mental disturbance. That's under features of renal failure. Yeah, so hypercalcemia, so muscle weakness and confusion. Then abnormal bleeding tendency because you have thrombocytopenia. Then amyloidosis in 5%, increased petechial bleeding, mild fever, night sweats, weakness. So my CRAB formula, it's usually hypercalcemia, so the C in hypercalcemia. So which will present with anorexia, vomiting, constipation, mental disturbances. Then R, so R is for the renal failure. A is for the anemia. And then B is for the bone pain, or these ones, the lytic lesions. So the bone lytic lesions, okay? That's how you remember CRAB. Those are the ones I usually remember, okay? I hope that mnemonic was useful. So CRAB, hypercalcemia, renal failure, anemia, then bone pain or the bone lytic lesions. Yeah. Then, yeah, so I think that's okay. So, what is this? Eosinophil. Why? So why is this an eosinophil? So for eosinophils, you check the background. So the lobes can't help us. So you check the background. Normally, in a picture of an eosinophil, they're usually pinkish. If I have a better one, yeah. Look at this one. Look at this one. You see, it's usually pinkish. So this one, it's not that pinkish, but it's an eosinophil. You can see the granules, they're usually pinkish, okay? Then one immunopathologic condition affected by the cell, so we have allergy. Then state the major cytokine involved in survival, differentiation, and chemotaxis. Interleukin 5 and 4. Okay? I think that's okay. Then this one, what cell is this? Look at the lobes. Neutrophil, yeah. Neutrophil, yeah, because of the lobes. You can count how many lobes? 1, 2, 3. For the eosinophil, then this one. This one is, so you look at the granules, kind of, I don't know, is it pink or orange? You know, we are not that good with colors. So I'm seeing pink, but it's supposed to be orange. Yeah. So basically, that's how you identify. Okay. Okay. And normally the eosinophils are usually bilobed. You can see, so 1, 2, 1, 2. So let's see. 1, 2, 1, 2. Oh, bilobed and orange. Yes. So the chart is saying orange. So we go with orange. Okay. So causes of, so this is the cell on the left, is the neutrophil. Causes of raised level neutrophilia, bacterial infections, CML, and note, it's not leukemia, only CML. Okay. Burns, necrosis. Then causes of reduced number, plastic anemia, drugs, HIV, autoimmune diseases. I think in a question like this, if you ever see reduced levels, the first thing that should come to your mind is bone marrow failure. So if you say bone marrow failure, you can't mention. So you can split it into a plastic anemia, Fanconi anemia, but start with a plastic anemia, then go to chemotherapy, drugs, HIV, except when you see an eosinophil. Okay, HIV. So um, HIV causes all reduced except the eosinophils. Okay, then autoimmune diseases, SLE, rheumatoid arthritis, those are the neutrophilia. Then identify the most common presentation of low neutrophil. So presentation, recurrent infections. Then identify the cell on the right. So this was the cell. So you can see these. So the granules are orange. Okay. Um, mm, Raised levels. I usually have a formula. Raised levels, which is eosinophilia. I usually say Pacman eats. So in case they ask 3 parasites, remember parasites is the first one. So helminths, you know, Ascaris, Strongyloides, all those helminths, the nematodes, they cause eosinophilia. Asthma, this is an allergic reaction. Type 1 hypersensitivity, increased level of IgE and eosinophilia. Chronic adrenal insufficiency, myeloproliferative disorders, allergic reactions, neoplasm, e.g. Hodgkin's lymphoma, and then the E, eosinophilic granulomatosis with polyangiitis. Okay. I'm seeing someone is asking me, I repeat on the HIV. So for the HIV, what I was saying is HIV causes decrease in all the cell lines except eosinophil. It causes something known as absolute eosinophilia, okay? So it will cause neutropenia, lymphopenia, which other cell line do we have? neutrophils, basophils, eosinophils. We've said it causes absolute eosinophilia, lymphocyte. Which other one do we have? Monocytes. Is there another one? Yeah, thrombocytes or the thrombocytopenia, anemia. Okay, that's for the HIV one. Monocytopenia. Yes, yes, yes. So all the cell lines we expect HIV except absolute eosinophilia. Then causes of reduced or Cushing's, glucocorticoids, stress, even the fact that some drugs, if you feel like you forget or you want to have an answer, just write some drugs. No need to give an explanation. Some drugs, just write some drugs. Yeah, the low levels. What is this? What can you see? Anyone in the chat? Hemorrhage on the conjunctiva. Yes, there's some bleeding here. And then look at this child's gums. You can see some bleeding at these spots. And then, yeah. What else can you see? Are these gums swollen slightly? Some bleeding. You can see this last molar, there's some bleeding here. And then, yeah, so those are the things you can see. So two conditions are present in this manner. So this patient has acute leukemia. So we have AML and ALL. State 3 tests useful for diagnosis as your differentials above. Quite a lot. So we start with cytochemical staining. So you'll say cytochemical staining. There are usually 4 stains that we use. Number 1, Sudan black B, positive for ML, negative for LL. Switch B myeloperoxidase, positive for ML, positive, negative for LL. PAS, positive for ML, especially M6. You know, there's subtypes of AML. So there's the M6 one. It's negative except for the M6 one, which is positive. Positive for LL. Esterases, M5, positive, M4 positive, negative for LL. And then acid phosphatase, negative for ML, positive for ALL. So how to remember this? I usually remember the ones that are positive for AML. So Sudan B-like, meroperoxidase, and the esterases ones, or the positive for AML. Now, if you know that one, knowing the rest will be easier. So Sudan B-black and esterases, positive for AML, and then PAS and acid phosphatase, positive for ALL, negative for AML. Then, so you can see this star, aura rod. They are crystallized aggregates of myeloperoxidase enzyme. So if they are aggregates of myeloperoxidase, you'll expect AML to be positive because AML is where we find the aura rods. Okay. Flow cytometry to differentiate B cell and T cell. So B cell cluster of differentiation 10, 19, 20. 20 the most important. Then T cell ALL cluster of differentiation 3. So CD3 cells. Bone marrow aspirate hypercellular marrow 20 or more blasts. So you have to remember that this should actually be your first point. Okay. Then chromosomal analysis translocation of at number 8 to 21. That's ML. Okay. Then this. So what is this? What do you see? So you see swelling of the jaw, good. And then, so what are the differentials? Three differentials. And then you have to remember this is a kid, so it's not an old person. Burkitt's lymphoma, Burkitt's lymphoma, Burkitt's lymphoma, ameloblastoma. This is a kid. So actually, I just want to start with that. I put a note. Ameloblastoma is mainly seen in adults. So if you write ameloblastoma, you'll be given a wrong. Okay, so that's what I wanted you guys to see. Osteosarcoma, yes, yes, yes. So the differentials we have Burkitt's lymphoma. So Burkitt's lymphoma is the first one. Okay, rhabdomyosarcoma, osteomyelitis, but this osteomyelitis is if it were a smaller mass. So don't write this. Metastasized neuroblastoma, okay, fibrosarcoma, non-Hodgkin's lymphoma, osteosarcoma. So if I were to tell, if you're asked state three differentials, start with Burkitt's, then rhabdomyosarcoma, and then non-Hodgkin's lymphoma, and then maybe osteosarcoma. Then you can write the fibrosarcoma and the metastasized neuroblastoma. They can't ask more than three. So Burkitt's, rhabdomyosarcoma, and non-Hodgkin's lymphoma. So don't write ameloblastoma or osteomyelitis. Okay. Test for definitive diagnosis, there are usually two, biopsy and FNA. And FNA, remember, is a screening test to see any cells that are not the abnormal cells. Okay, regions in Kenya where these patients likely come from. So coast, western, Nyanza are the most places where you'd find this. Okay, and then this is what I was saying. So this one. So what cell is this? Myelocyte. Yes. So this is a myeloblast, not a myelocyte. Myelocyte is the mature one. It is an immature cell, so it's a blast cell. So it's a myeloblast. Okay. Then if I told to identify this is a aura rod. Okay. As I've said, aura rod are the crystallized myeloperoxidase aggregates. Disease AML. Three classical clinical presentations. This one. So one, anemia, thrombocytopenia, and neutropenia. So if it's anemia, you say symptoms of anemia. So the fatigue, blah, 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 dyspnea. If it's neutropenia, recurrent infections. If it's thrombocytopenia, easy bruising or bleeding, okay? So reduced RBCs, pallor, palpitations, fatigue, recurrent infection, increased tendency. Investigations, the same. CBC, HB is reduced, white blood cells, increase in majority might be normal or reduced up to a third of the patients. Platelets, reduced. PBF, myeloblasts, presence of aura rod, red cell, nomocytic, nomochromic in a PBF. Then a bone marrow aspirate, hypercellular marrow, at least 20% blasts. Cytochemical stains, as we had said, Sudan B black, positive, esterases, positive, or myeloperoxidases, positive. And then the rest are negative. So the PAS and the acid phosphatase. Then this one, what is this? Oh yeah, you look at the nucleus. It looks like, I remember when we were doing the tutorial, someone said it looks like a fetus. And I've never forgotten. So yeah, so fetus shaped or kidney shaped or bean shaped nucleus. So which cell is this? Monocyte, yes, it's a monocyte. Monocytes. So I don't think you'll forget fetus-shaped nucleus. It's a monocyte. And this, so this is also a monocyte because of the kidney-shaped nucleus. So kidney-shaped, pin, horseshoe-shaped nucleus, grayish cytoplasm. Also look at the cytoplasm. Look at the color. I was seeing somewhere it's written, it looks like a frosted glass appearance of the cytoplasm. It's grayish in color. Functions of the cell. So cytokine production, phagocytosis. So similar to macrophages. Because we know that the macrophages are usually differentiated from the monocytes. So basically they're just asking what are the functions of macrophages. So cytokine production and phagocytosis. Okay. Causes of raised and decreased counts. So monocytosis is increased. So we have chronic infection, TB, typhoid, malignancy, e.g. myelodysplastic disease, connective tissue disorder, e.g. Crohn's, UC, postplenectomy, protozoal infection, malaria, and Kalahari. So you remember I said parasites. So the helminths, they cause eosinophilia. And then these protozoal infections, they cause monocytosis. Okay. So remember that. And then the chronic infections like TB and the malignancies. Then monocytopenia. Remember I said HIV, all the cell lines except eosinophilia. Drugs, some drugs you'll never get wrong if you just write some drugs, chemotherapy, and aplastic anemia or bone marrow failure. Then also ML. Okay. Osmotic fragility. So you can see in this graph, we have lysis in percentage and sodium chloride. Okay, so these are lysis. When you say lysis, these are the RBCs placed in the sodium chloride. So for example, in a concentration of 0.2, 100% of sodium chloride, 100% of the RBCs are lysed. At 0.8, 0%. So you basically put RBCs in different concentrations of sodium chloride, then you draw your graph. So for example, the normal range you expect at 0.2, 100% are lysed. At 0.4, 60% are lysed. At 0.5, 20% are lysed. But now, look at this condition. If they were to draw a graph here, and to draw another graph here, and then they label A and B. So A has shifted to the right, B has shifted to the left. If A is hereditary spherocytosis, which conditions would B be? Pun unintended. Which conditions would B be? So anyone? So to interpret this, it's like saying at 0.5, you expect 20% of the RBCs are lysed, but here 40% are lysed. At 0.5 is the best you can use. Sickle cell and thalassemia, yeah. So if you're asked what is the technique, osmotic fragility, obviously they won't use this image, but this is the best image I found. I'll briefly outline the principle. So I think I've explained, you just look at the graph. It is used to measure erythrocyte resistance to hemolysis. The erythrocyte is the RBC resistance to hemolysis while being exposed to varying levels of dilution of the saline solution. You see, like there's 0.1, 0.2, 0.3, until 0.8, and then you see how many of the RBCs have lysed. Then, conditions that may cause the graph to shift to the left and the right. So you can see in hereditary spherocytosis, at 0.5, 40% have lysed. So meaning they break easily. So meaning the membrane of the cells are easily broken. But now, to the left, it means that the membrane of the the membrane of the RBCs are not easily broken. So of which are thalassemia and sickle cell disease. Okay. Yes. So what is this? Okay, first of all, you'll be asked to interpret. So who will interpret for us on the chart? So WBC of 21.6, 5.7, platelets of 224. So WBC is high. So the normal is 4.5 to 11. So this is high. RBC? Oh, so we've said elevated. RBC, we said 4 to around 6. So this is normal. Then platelets, 150 to 450. So this is normal. So those are the interpretation. And then causes. So look at this. It's quite elevated. So leukemia, an infection. So pyogenic infection, this is a bacterial infection. Sepsis, burns, chemical poisoning, tumors, inflammatory, acute rheumatic fever, thrombosis, thyrotoxicosis. 3 other tests. Say the 3 other tests for the above. So BMA, PBF, WBC differential count. What that means is you now do the differentials of this. So if you want to see if it's increased neutrophils, or is it lymphocytes, or is it monocytes, basophils, then a blood culture to check for the presence of bacteremia. Yes. Cytochemistry, immunophenotyping for antigen surface markers to identify the cells. So is it T cell or B cell that are raised? Okay. Then so for this one, let's interpret in the chart. WBC, HB, low. Is WBC low or normal? MCV, slightly low. WBC normal, low HB, normal WBC. MCV, low MCV. So, and we said MCV is about size. So there's a decrease in size. HB is about concentration of hemoglobin, so low, meaning so there's an anemia. Platelets, normal, so there is no thrombocytopenia. So is the WC normal or elevated? Oh, sorry, or reduced? So um so if you were to use the KNH values, it's usually 4 to 11. If you, I'm sure if you Google, sometimes you'll see 4.5 to 11. But it's advisable use the KNH one, so 4 to 11. So it's normal. HB low, MCV low, platelets normal. Then if you're told to interpret this, microcytic anemia, then causes, um, for causes, I tried to differentiate them into three causes, but there's usually a formula, tails, I usually say tails. So the formula is usually tails, where T is the thalassemia, A is anemia of chronic disease, sorry for the short form, AOCD, anemia of chronic disease. Then I is for iron deficiency anemia. Then L is for lead poisoning. And then S is for sideroblastic anemia. Okay. So deficiency in iron metabolism, iron deficiency anemia, anemia of chronic disease. You remember that in anemia of chronic disease, the ions are in the macrophages, and then a transferinemia. So this is a transferinemia. So transferrin, so A means no, so no transferrin in blood, and transferrin no is the transport agent of iron. Then thalassemia, then porphyrin and heme synthesis, sideroblastic anemia. Two relevant tests apart from blood counts, useful. So remember I said PBF, CBC, and they've said apart from blood counts. Yeah, so PBF, microcytes, hypochromia, anisocytosis, so different size, different shapes, HB electrophoresis for thalassemia. Then BMA, absent iron, should be stores in iron deficiency, then sideroblastic, so presence of sideroblastic anemia. Yeah, so what page are we in? 29. So you see, you have a lot to cover, but I hope it was helpful. I'll stop sharing right now.